Now is your chance to ask questions of the esteemed and illustrious panel, who may know all of the answers to all of your questions. I hope they do. So, who's going to kick us off? Having trouble seeing. Don't be shy.
Somebody's there.
There's a question there.
Hello, we had a discussion about higher education institutions and how we can help them to prioritise prevention and incorporating making every contact count into undergraduate pre-registration curricula. I think Lydia wanted to add something.
Yes, just to add that the comment earlier this morning about the fact that there's lots of great resources and e-learning resources out there, and it's about making sure that people are accessing them and using them, I think applies to what we're doing in our universities as well, that we need to make sure that there's lots of resources available to our students, but it's just not embedded in their curricula.
Anyone going to comment on that?
We were having a conversation at coffee actually, and we were saying about how important it is to start early within people's training programmes. So as well as those that are already frontline staff at the sharp end, you know, if we're talking about the change cycle, it's a good place to start while people see it as part of their core work. So whether that be GP training, physio, whoever, seeing this as part of it. So I think that's a brilliant idea. And also that bit about not recreating the wheel, there's lots of resources out there that we should be consistently using. So I would agree.
I know that in some places the right requirement to do that sort of thing in the curriculum, and that may or may not work, I don't know. But having taught on the public health module for year 2 medical students at least for quite a long time, I can tell you that they're not really interested in public health, they're interested in chopping bodies up. And the only way that we made it interesting, I think, is by introducing real people, and we brought in people who've been drug users and a whole range of people, because I'll go back to the art of public health, and I know I keep saying it, but the science is absolutely essential, but it's how you deliver the science, and you've got to make it attractive and interesting to the medical students, because it really is not the top of their priorities. So we've got to find really, really interesting, creative ways to get messages across. You know, I mean, we got an example from Ollie this morning. Some really quite simple things can have really dynamic impact, but I don't think we're terribly good at it.
Thank you. Any other questions? Yeah, there's a few there, and then right at the back.
Hi, Susan Blundell from Leeds City Council. Just a plea really. I think a lot of the speakers sort of mentioned it, and I lead on MECC in Leeds City Council. And very much MECC, my belief, and I think you said it, is really it's relevant for the whole workforce. My challenge really is who's it not relevant for? I've yet to meet somebody who does a job it's not. But I think when we develop resources and things, we still go back into our silos, and very much I see things that's very health orientated, and also when we're trying to access resources and things, it's not very system wide. So it's really just a plea that when we think about when we're developing these things, that we really do think that way. I think what the number was is 20 million, and I think it's really important. It goes back to Val's about the art. People need to be able to identify and rationalise themselves that this is my business. So it's really just a sort of a plea, really, and thoughts from the panel.
I'll take chair's prerogative. Hi, Susan, it's been a few years. Yes, I completely agree. If these kinds of things are full of public health, failed, dismally failed, and it's turning it into something that's not health. As soon as we mention the word health, we automatically mindset default to a certain sort of stuff. I increasingly don't use the word public health in Sheffield, I use the word well-being instead, and a lot of people engage with that a lot more. So welcome other thoughts.
Yeah, I think I completely agree with that. I mean, I find myself as a GPM in conversations not about health, but just about tuning to the things that matter to them. So it's more about feeling on top of your game, feeling having more energy, not having poor sleep, having better sex life. It's the things that matter to people, isn't it? And as soon as your language is tuned into what people are working on, you're away, aren't you? So I won't say too much, I'll pass that.
I'll just say something about our website, because I completely agree with your comment. For us in Health Education England, our core business is the NHS, so we have a little bit of a battle on our hands with our sort of comms team, when everything that goes out from us is NHS branded. We know it's an issue, we're working on it, but I completely agree with you, and that's where we want to get to as well.
Can I just add to that? I started off the morning by saying how brilliant it'd been working on planning this, because there wasn't just Health Education England and Public Health England. We had people from the council, a whole host of people involved, and it really did demonstrate what great partnership can achieve, and it was a pleasure to work together. Just yesterday, poor Danny, and I don't know where she is, but Danny, who's worked her socks off, was still fighting with our comms team because there was more than one logo on this. And I just think we've got an awful long way to go. You know, I feel like saying physician, heal ourselves. But, you know, how long have we been advocating partnership work? How long have we been saying we work together, we can't work alone? But it's still happening now, and it's a constant fight.
Okay, I think there's a question right at the back.
Hello, I'm Rachel, so I work for Better Start in Bradford, which is one of the Better Start projects in the country that are working to do health and wellbeing work with very small children. And I'm a midwife, so I work to explain that to midwives and to explain midwives to everyone else. So this is a plea really around my experience as a midwife. So I went into midwifery because I was entirely committed to a social model. I was a community development worker before that. I'm not unusual. And then since the 70s, midwifery, which to me is a social health promotion, family development service with a critical care block on it, has been put into acute hospitals. And so, although most midwives, especially in the community, are highly motivated on these agendas, they're physically unable to do record keeping, a physical examination, and have a meaningful conversation in 15-minute blocks when they're looking after 100 to 120 women on their cases. So we've got a pilot where we have successfully added in resource to drop the caseloads and to add time onto those appointments, and we are finding that is contributing to this agenda. But unless we have big structural change at STP level, where we remember the acute services are going through their own transformation, like how can we possibly prevent things for the next generation? Do you know what I mean? I just see time and money being wasted consistently, and public health workers are exhausted. So it's no use just telling them how to have the good conversations. How are we going to make the drivers to reorganise the services around families?
Any takers? Anyone disagree?
Can I just... I was supposed to do this at the beginning, but Greg pinched the microphone. Unfortunately, there are two people who can't be on the panel today, and one of those is Frances, who's sitting there. And she may have had a really good answer, but unfortunately she works for Public Health England, which is civil service, so she can't speak. She has got her lips sealed. And the other was Julie Weldon, who sadly had a bereavement. But I think, yes, for those people who've got the ear of the strategic managers, then it's a very, very important message. But I think the STPs are in different stages of disarray or array as wherever they might be, and I'm not sure that working in such a sophisticated way yet. I may be wrong in South Yorkshire.
You're definitely wrong in South Yorkshire. So as someone who's a DPH on the STP Collaborative Board, I can know this is a South Yorkshire answer. The narrative around our STP is the right narrative. The challenge is to turn the narrative into some action, which is, as you all know, much easier said than done. There are a number of burning platforms in acute hospitals. I often say to the STP board, in fact I say at every meeting, until you sort out outcomes, there's no point talking about money. Until you sort out inequality in outcomes, there's no point talking about outcomes. They're really easy things to say, but my personal challenge for me is that getting that across to a mindset of NHS senior management who've been barraged for 20 years now to think in a certain way is a very, very difficult change. But it ain't going to happen unless we make it happen. Back to where I started. So keep on it in whatever level you are, wherever you are in the health and care system, doesn't matter, just keep on that path. There's a question right at the back.
Hi, it's a question for Ollie. The MECC model around chronic pain. Yorkshire and Humber region, quite heavy spenders on prescription opioid medications, and you mentioned briefly at the end of your presentation around the model and the chronic pain element, and I just wondered if anybody, any of your minions in Barnsley had put down their prescriptions as a result of your MECC model, and if that had been sold back to the CCG, or if you'd had any conversations around that, if it had saved any GP time, and if you considered that as a selling point of MECC back to CCGs.
Thank you for that question. That's, I think that's a great example of the sort of thing we're talking about, really, because I know as a healthcare professional, as a GP with limited time, that often with complicated conditions like chronic pain, the easiest thing to do is to reach a prescription pad and particularly give someone an opiate. The last 10 years there was a big publicity around how opiates are okay for non-cancer pain, and everyone's gone, great, thank goodness, we can just give them something to get us out of our room. And actually the real solution to people with a complex condition like chronic pain is much more in line with the sort of things we've been talking about, really. Giving people time, understanding where they're coming from, and building their own internal resilience, building on the assets they've got. But that does take time and effort, and I guess that's what we're often up against, really, is how do we find the time, like the last lady said, you know, these things take time. You know, you can't rush them in a 15-minute appointment. So I guess, twisting around a bit, but the point I was trying to get across in my story was that the other crucial part of this is identifying the things that we don't do to allow us to put time to the people that really need it. And I think that's equally important in this conversation, because it's so easy just to say, oh, just do more, just add this on, just squeeze this in. And we absolutely can't do that. And if we do try and do that, you just don't do the stuff justice that you need to spend time on. So that I would say that's a plea for us, is to identify the people who are doing okay. You know, where we can be light touch, and we can, you know, you can always do things for people, but it's not what we should focus our efforts. So that would be my point, really, if that helps to answer your question.
I'll just briefly add to that. It's a non-MECC point, but it's about opioids. There's a big push in America to move away from opioids. We haven't quite caught up with that in this country yet. But it's not really a point about MECC, but we just need a long-term campaigning approach that big scale use of opioids actually probably does more good than harm, and there are different ways.
More harm than good.
Sorry, I did mean to say more harm than good. You know,
more harm than good.
More harm than good. And that isn't a message that the public are widely aware of. I suspect it's a message that a lot of clinicians aren't that widely aware of because of the last 10 to 15 years. So MECC is important, but it's not the only part of that, the opioid thing. Time for a few more questions, I suspect. Chris, I think.
Hiya. It's an interesting phrase, isn't it, lifestyle? Given the fact we've all got one, how do we address problematic lifestyles before it's an issue secondary to a primary health or mental health problem?
Clever panel.
Let's pass that on.
Let's pass that one. Which of you love what part?
Yeah.
There's something about promoting the well-being model, isn't there? And I mean, there's a project that we just kicked off in HE around pathways to health. It's a piece of work they've been doing in the Northwest, working with organisations that work with schools. And it's almost, starting at that very early stage, getting the messages out about why it's important, why well-being is important. I'll stop there.
I would also say when it comes to things like lifestyle, you mustn't underestimate the impact of the social and cultural context, because that tends to shape people's lifestyles, certainly in terms of behaviour change. So that kind of sets the scene, and that's something to bear in mind. Yeah.
I mean, I think it's pretty true that, we all have the right to choose a poor lifestyle, don't we? But I guess what we're talking about here is people having the capabilities to understand the whole totality of their decision making, and not just to be sucked into something that actually isn't really what they want, but actually it's the way they get forced to go because of the capability set they have at the moment, their health literacy and so on. So there's plenty of people who are highly activated, PAN level 4, who choose the things that are unhealthy, and I think that's not our role to stop that, but it is to empower people who are lower activation levels to take more of a lead in do what they want.
I horrified our transformation board recently, but there's nothing unusual there. We were talking about inequalities, and people didn't really seem to get inequalities and how you were much more likely to make a sensible choice if you'd got, you know, if you went to a good school and you'd got a secure family and all those things. It's really meat and drink to us, but some people just did not get it. And some, I won't say who because it's very important, but it just said, look around the room, everybody's got a Fitbit on. You know, and I said, I worked with people in Wakefield that the only way they'd have ever got a Fitbit was to go out and nick one. And they just don't get that, you know, it really does mean about changing a whole raft of populations, making significant changes to people who will never see any different. You know, I work in all sorts of different sectors, and I still do some work with the criminal justice sector, and I hear people talking about John Willis Smith, who's at the youth offending panel. And I think John Willis Smith, I locked him up when I was a copper about 50 years ago. And actually it's his granddad. But there's nothing changed. The whole, you know, they all live on the same estate. And we've got to do something really, really significant to change that. And it really does mean starting very, very, very young. You know, changing cultures is the hardest thing to do.
Time for one or two more questions if you are. I think there's a hand up at the back. Yeah.
Hi, my name is Celia Jackson Chambers and I work for a small charity supporting people with mental health problems. And I wanted to, I found this morning very interesting, but it's very physical health focused, and I wondered how, in the view of the panel members, making every contact count could be affected and effected around mental health.
DP from Rotherham made a point about that this morning.
Yeah. I think just to say that when the national working group was looking at MECC, mental well-being was absolutely in the core of MECC alongside all the physical things. So and we saw it on the video about active listening, kind of just having that conversation, just listening to people about how are you and those kind of things can really make a difference. So it's absolutely a core part of MECC as far as the national work is concerned.
I think that what you said is a really good point, and I think that bit about listening, starting where people are and not underestimating that self-efficacy can have a powerful way on people's journey of the patient activation model as well. But also we know that some of the lifestyle things, such as being more active, also can have a positive effect on people's mental well-being. So I think there's a two-way street there about what we can do, and we need to absolutely make sure that sort of mental health and well-being is a key part of making every contact counts.
Yeah, I think this also ties into the narrative that I spoke about, which has been touched upon. Just giving people a chance to articulate what's happening in their lives can apply as much to mental health as it can to physical health. And although I didn't make that explicit, that would have been my intention.
Yeah, I completely agree. I mean, I didn't want to come across as just physical. I mean, I think when you ask people what matters to them, they tend to set the agenda, don't they? And very commonly, that's what comes out in primary care, for sure. I don't know, I guess there's a wealth of resources in the room. Should we be doing it differently in a mental health context, or does it kind of link together?
I'm going to get to think about that question over lunch. I'm going to call a halt there. The panellists are around over lunch, so you can ask them questions all over lunch. I always say never work with children, animals or Wi-Fi. That's very brave. So before we go to lunch, we're going to have one last go with the video.